Dobré odpoledne, dámy a pánové. Já vzhledem k tomu, že jednacím jazykem dnešního slavnostního odpoledne inaugurační přednášky hostujícího profesora Lékařské fakulty univerzity Palackého je angličtina, tak vás pozdravím takto v češtině a budu dál mluvit anglicky, když to volíte. Dear Mr. Rector, dear Mr. Dean, let me please welcome you at the ground of the Department of Neurology of Faculty of Medicine and Dentistry of Palackého University on Olomouci. We gather in this historical lecture hall, which has been transferred from the church, which has been built in 1950 as the last sacral functional building in Moravia. It has been designed by Professor Čermák, Professor of Architecture in Prague, and we are very proud that we do have such a historical lecture hall. So welcome and thank you for coming. I would like to start this session by the introduction of our new visiting professor. We will put short presentation there. Our new colleague, Professor Hans-Peter Hartung, with all these academic titles you've seen, MD, PhD, Fellow of Royal College of Physicians, European Academy of Neurology, Fellow of American Academy of Neurology, and Fellow of American Neurological Association, is a professor of neurology at the medical school in Düsseldorf, at the Department of Neurology of Heinrich Heine Universität in Düsseldorf. Professor Hartung is probably one of the most important persons in the field of neuroimmunology and field of multiple sclerosis all over the world. He is for sure the most important global opinion leader in this field. He is a member of 18 scientific societies, mainly neurological and neuroscience. He is a member of the editorial board of 32 scientific journals, including Annals of Neurology, Nature Reviews Neurology, Journal of Neurology, JNP, Muscle and Nerve, European Journal of Neurology, and we are very proud that he's a member of the editorial board of Biomedical Papers. Thank you, Peter. He is the author of more than 1,000 peer-reviewed original and review papers on the pathogenesis and treatment of neuroimmunological disorders, in particular multiple sclerosis, Guillain-Barré syndrome, and respective animal models. He has edited 9 scientific books and is the author of more than 100 chapters in scientific books. His Web of Science citation record covers more than 72,000 citations, and his H index is 116. You can see on the table list of Peter's 15 top papers, and we are very proud that Peter even has some papers co-authored by Honza Mareš, head of our multiple sclerosis center, or MS center, and I will show you these papers only from the last 2 or 3 years, which they have in neurotherapeutics, in neuroinflammation of neurology, and in the current opinions. So that's a short introduction of our new visiting professor, and I would now ask Professor Zadražil, Dean of the Medical School, to welcome our new colleague.
Dear Professor Hartunger, dear Professor Kaňovský, dear colleagues, ladies and gentlemen, I am glad to be here, and it is my pleasure to greet and welcome Professor Hartung on the soil of our Faculty of Medicine and Dentistry, which is the second oldest in our country and was founded 1573. I would like to say that I hope everyone in this lecture hall have great admiration for your excellent scientific output. For many of us, I think for all, it is inaccessible performance, scientific performance. Professor Hartung, I wish you nice time here in Olomouci, in our beautiful historic city, and good luck. Thank you very much for coming.
We thank our Dean, and now I will ask His Magnificence, the Rector of the University of Palackého, Professor Martin Procházka, to present the official certificate of visiting professorship to Professor Hartung.
Spectabilis, honorabiles, cives academici, lieber Hans-Peter, herzlich willkommen in Olomouc. I will switch now to English. Dear Professor Hartung, it's my great pleasure and honor to welcome you on behalf of the leadership of the university. And let me give you this certificate, which is saying that you are now appointed as a visiting professor at the medical faculty of Palackého University based upon the solution made by a scientific board of this faculty. It's a really great pleasure for us to have you here and to cooperate with you. And I'm thankful to head of the neurological department of this medical faculty, because this is the second time for us to be here in this great opportunity. If I'm correct, just yeah. Okay, so it's a really big pleasure for us, and enjoy Olomouc and have a nice time here.
So we thank both gentlemen, and now I will ask Honza Mareš, who will be the moderator of this session, to start the lecture and then continue with the discussion.
Thank you for the word, and now let me introduce and ask Professor Hans-Peter Hartung to give the lecture about the advancing a perspective of multiple sclerosis treatment. We are happy to have you here. Thank you for coming.
Thank you very much. Magnificence, spectables. Professor Kaňovský, Professor Mareš, dear colleagues and friends. First of all, I have bad news and good news. The bad news is I won't be able to speak in your language, unfortunately. The good news is I won't speak in German. I'd really like to express my gratitude to the university and the faculty for appointing me as a visiting professor. This is my, I think, third time to Olomouc, a beautiful city, and I appreciate the long-standing friendship with the colleagues in the Department of Neurology here. So I would like to give you my personal perspective of the quite amazing evolution of treatments for the disease multiple sclerosis. And I think you are not all neurologists, not all MS specialists, so please allow me to start with some introductory background on this disease and its cause, its pathobiology and pathogenesis. And then I will come to a review of the astounding development of disease-modifying treatments for disease that until 30 years ago or so was really not treatable except for steroids for attacks. I will also very briefly address some of the emerging treatments and developments that are ongoing before I conclude. So just by way of background, historically, I just want to show you a first or good description by a patient of the cardinal symptoms of this disorder. This is Augustus d'Este, the illegitimate son of King George III of England, who meticulously recorded his symptoms. And you see that at the age of 28, he had a sudden transient visual loss. He had weakness, clumsiness, numbness, dizziness, bladder disturbances, tremor, and spasms, erectile dysfunctions, and he ended up in a wheelchair. Now, we credit a very famous neurologist that neurologists amongst us, of course, are very familiar with, the first professor of neurology at the Hôpital Salpêtrière in Paris, Jean-Martin Charcot. In the 1860s and 70s, he really delineated the classical features of multiple sclerosis. This is a disease that worldwide affects some 2.8 million individuals, and there is good evidence that over the past 20, 30 or so years, its incidence has been rising for a number of reasons. The disease takes different course. Usually patients initially have a relapsing course that then transitions to a more progressive clinical course, and it is associated with significant disability. You see that here, where utilizing a special disability status scale, you see from normal until death, various stages that patients go through. Now, fortunately, I think we can safely say that with the evolving treatments and the treatments that have become available, the outlook is much better. But still, data from Scandinavia have convincingly shown that the life expectancy, apart from is shortened, and of course quality of life significantly impacted on, placing a big burden on the patient, his or her family, caregivers, the healthcare system, society at large. Let me just briefly show you what are the cardinal features. The disease starts usually with either of three presentations: optic neuritis, acute visual disturbance or visual loss, brainstem syndrome like double vision, incoordination, ataxia, or a myelitic presentation characterized by weakness of the legs and gait disturbance. Now, it is possible to make the diagnosis early on adhering to some cardinal features. You, first of all, have to exclude diseases that mimic multiple sclerosis. And secondly, you have to adduce evidence for a dissemination in space and in time of lesions, either causing symptomatology or being silent. And of course, the advent of MR imaging has greatly facilitated this. And there have been repeat updates of these diagnostic criteria, and we are currently in the process of developing the next version. This allows to make the diagnosis very early on with high fidelity. Very important, given the strong body of evidence that the prospects for patients are best if you initiate therapy early on. So just very briefly, the pathobiology of MS. One cardinal feature is in the pathology, multifocal inflammation, demyelination, shown here by the absence of a myelin staining, and axonal damage, axons or neurons. And over the course of the disease, the relative contribution of inflammation and neurodegeneration change. And initially, there is also the ability of the brain and spinal cord to foster repair, remyelination, regeneration. But as time goes on, this capacity gets exhausted. We also learned over the recent years that axonal damage to the neuron occurs from the word go and involves multiplicity of mechanisms. Initially considered to be a disease of the white matter and focal in nature, it has also become clear that the gray matter is involved. The cortical regions are very important in terms of the cognitive impairment. And the disease is really widespread and even occurs in what is referred to as normal appearing white matter. If one looks at the spectrum of pathological changes occurring as the disease advances, we have this relapsing, remitting phase characterized by waves of inflammation or invasion of immune cells from the periphery across the blood-brain barrier into the central nervous system. New focal lesions more so occurring in the white than the gray matter. But when the disease continues to be progressive, there's diffuse injury, cortical demyelination, the slow expansion of existing lesions, and a curious phenomenon called compartmentalized inflammation. I'll come back to this. And in the late progressive stage, we have the superimposition of comorbidities and aging and the associated pathological alterations that amplify the underlying damage. If one sort of takes a slightly different view at the same evolution of the disease, inflammation is characterized by conduction block, by the failure to safely propagate nerve impulses, demyelination and axonal injury, and a predominance of the adaptive or antigen-specific immunity over so-called innate immunity. Very importantly, as I mentioned, the initial capacity to promote repair would, on top of what we call brain reserve, mask the damage and the underlying damage. So it's not either visible or patients recover from acute attacks. However, with an increasing accumulation of neurodegenerative changes, those loss of axons, neurons, remyelination failure, innate immunity becomes more important. There's this less overt compartmentalized inflammation in the brain, and as mentioned, a higher vulnerability to comorbidities, cerebrovascular, diabetes, etc., and the changes of aging, and a depleted repair and compensation capacity. If one attempts to condensate the multiple lines of evidence for an immune-driven process basically underlying the pathology of multiple sclerosis, one can come up with this. There are potentially autoreactive T or B cells contained in the immune repertoire of an individual destined to develop multiple sclerosis. There needs to be an activation that drives these cells across the blood-brain barrier. Once they've invaded the central nervous system, they get reactivated. And this then results in proliferation of T cells that instruct local macrophages, microglia, to damage the myelin sheath and the axons. Very importantly, and I come back to this, the role of B cells has been revisited and reinforced. Initially, we thought it's just their production of autoantibodies that through activation of the complement system would damage the myelin sheath, but there are other ways. And a recent focus of interest has been the astrocytes that not only proliferate and sort of produce a gliotic scar in the brain, but they have probably other factors early on in the disease. Now, it's a multifactorial disease. So genes, the alterations in the immune system, and environmental and lifestyle factors work in synergy to determine susceptibility of individuals to contract multiple sclerosis. I'd just like to point out that there are a number of haplotypes and SNPs that in aggregate contribute to the susceptibility, and importantly, lifestyle and environmental factors, infections, obesity, coffee consumption, smoking, sunlight exposure, vitamin D, they all play an important role, and a recently re-emphasized focus is on the role the gut microbiota play in driving the aberrant immune responses. Now, something that has also been re-emphasized earlier this year, propelled by a fantastic study published by the group of my friend Alberto Askerio, is the role of the Epstein-Barr virus, the causative agent of infectious mononucleosis. There's been a long story about the higher propensity of individuals infected with EBV and suffering from mononucleosis to later on develop multiple sclerosis. And this paper in Science published earlier this year had the wonderful opportunity to interrogate a biobank and data from the US military. Whenever a young male is conscripted, blood is taken initially to look for HIV infection and then biannually. So there is an impressive set of data from some 10 million people. And these colleagues at Harvard looked at different time points in these samples whether there was evidence for an infection with EBV or whether this infection developed over the years. And what they found is that those individuals that became EBV positive, i.e. infected, had a 32-fold increased risk to develop multiple sclerosis. This is unparalleled by any other infectious agent. And how could this work? We know that EBV infects B cells. B cells exit the germinal center, enter the circulation, and can access the brain. And through a number of mechanisms, I don't have time to go into the details, this then sets in motion an inflammatory cascade damaging the neural parenchyma. And one sort of hypothesizes that against a genetic predisposition and environment and microbiome composition in the gut, latent infection is relevant, a process called molecular mimicry. Components of the EBV virus share structural homology with proteins on the myelin sheath, and the modulation of the crucial drivers of MS immunopathology B cells apparently play together to either ascribe a role to EBV as a trigger or maybe even a causative agent in the genesis of multiple sclerosis. And this has led to renewed interest and research efforts to further define this and also to find ways to perhaps prevent this if we were to be able to identify patients or individuals at risk. And we probably benefit from the COVID pandemic and the vaccination technologies that have become available. And there are several attempts ongoing to develop an mRNA-based vaccine. Now, against these advances in our understanding of the underpinnings of the pathobiology of multiple sclerosis, we see this very dense development of disease-modifying agents over the past 30 years. It all started with beta interferons as injections, something else, glatiramer acetate, and then a very important step, a monoclonal antibody became available, and then oral agents, and more recently agents that specifically target B cells. So for a disease like MS with an intermediate prevalence, it's quite amazing what has happened in recent years. There's still unmet need for the progressive stages of multiple sclerosis. So if one looks, and again, I don't want to go into details, but at the various crucial players in the pathogenesis of multiple sclerosis, at almost each and every checkpoint in this cascade, there are targets for therapeutic interventions with the B cell depleting agents, agents that act on T cells, agents that trap autoreactive lymphocytes in the peripheral lymph nodes, and hence prevent access to the central nervous system. And it appears that some of the agents are able to enter the central nervous system and exert their therapeutic actions in situ. Now, a very important breakthrough has come through the administration of monoclonal antibodies of various sorts. You know, these are engineered antibodies, and I listed those that have been used and are used in multiple sclerosis, but also other autoimmune disorders. The first important development was the anti-VLA4 monoclonal antibody natalizumab. with a significant contribution from the Czech Republic, an agent that prevents the lymphocytes from the periphery to enter through the blood-nerve barrier. This resulted in a significant decrease in the number of relapses and in MR metrics and mirrors of inflammatory activity, gadolinium enhancing lesions. These are placebo treated patients, and these in blue, those that had received natalizumab. So you see a very important impact. However, the drug comes rarely with a very significant complication, the so-called progressive multifocal leukoencephalopathy, or PML in short. So let me briefly talk then about the first drugs that became orally available. That's, of course, for patients' usability, tolerance, adherence important. The sphingosine 1-phosphate receptor modulators. And basically what they do in the periphery is to retain T and B cells in the lymph nodes, so as to make sure that none of these autoreactive cells can reach the central nervous system. Just one example, I mean, these modulators address different receptor subclasses. Siponimod, this was the first drug to show efficacy in a specific stage of the disease, secondary progressive multiple sclerosis. And it was shown that siponimod was superior to placebo in delaying disability progression. For example, here the time to develop disability was longer on siponimod than on placebo. Now let's have a look at those agents that hit the B cells. The B cells accumulate particularly on the surface, subpially in the meninges, and there is, as I mentioned, this compartmentalized inflammation that is composed of a multiplicity of cells, both B and T cells. You can consider this really a mini immune system in the brain and spinal cord. And this is a graphic representation from a recent review. You see how we now conceive to the B cells to act again, multiple ways, activating T cells, generating antibodies. So this is a very interesting and active field of research. The important thing is that it was possible to delete specifically those B cells. And you may recall the evolution of B cells from the bone marrow, the stem cells, to the plasma cells circulating in peripheral blood. And during the evolution of the, or ontogeny of the B cells, they display certain differentiation antigens. And the CD20 antigen is expressed on this, on these populations, not the stem cells, not the peripherally circulating cells. And there have been a number of studies that clearly pointed out and provided proof of the pudding that B cells are important, that if you deplete B cells, you exert a major beneficial effect on the disease. And a humanized version of such a monoclonal antibody demonstrated superior efficacy both in relapsing multiple sclerosis and, importantly, and for the first time, in a course of multiple sclerosis called primary progressive, that is, no preceding relapses, but from the word go, inexorable progression of the disease. And you see here that this monoclonal antibody caused some reduction in the risk of confirmed disability progression. The most recent one of these monoclonal B-cell directed antibodies is obinutuzumab, that was compared with an active, often used drug, teriflunomide, and it also significantly decreased the annualized relapse rate and decreased disability progression and increased the percentage of patients experiencing improvement. So we are here with this gratifyingly broad arsenal of drugs. How do we integrate that knowledge into the management of patients? And there have been traditionally two approaches. The escalation approach, whereby you use initially a moderately effective drug that has a very safe record in terms of adverse events, or you utilize an early frontline high efficacy approach, where you maximize the exposure to the anti-inflammatory effects of the drugs early in the disease when it's most likely to be beneficial. Again, I don't have time to go into the details, but we can, of course, discuss this later on. It's very important that one uses high efficacy drug early on, because there's now a large body of evidence from real world data to show that if you initiate treatment early on, high efficacy treatment early on, you significantly delay the evolution of disability and better the outcome in the individual patient. There's also a very interesting study from Denmark and Sweden. They have a national registry, and they have a different attitude in the use of disease-modifying agents. For example, in Sweden, rituximab, one anti-CD20 monoclonal antibody, is the most frequently used drug. And these colleagues compared the time to disability or time to a relapse and found that patients in Sweden do much better. And this is because they initiate treatment early on with high efficacy drugs. And this will, I am pretty convinced, generate a paradigm shift. And we also await a couple of controlled trials that could corroborate this statement. So just to list a couple of other approaches that may enter the therapeutic arena in the not too distant futures. BTK inhibitors, I will talk about this, autologous stem cell transplantation, and another series of drugs, and this is from a recent review. So the field is very active, and hopefully newer and more powerful treatments will become available. What I haven't talked about is repair promoting remyelinating strategies and the use of the concept of personalized or individually tailored medicine. Now, I mentioned earlier on that there is a capacity to repair early on in the disease. However, as the disease develops, this capacity is compromised. We do find precursors of oligodendrocytes. Those are the cells in the central nervous system that myelinate the axons, but somehow they cannot differentiate into remyelinating cells. And there are a number of reasons. And if one were to identify those reasons and molecular blockers of this process, one might foster remyelination. And there are potentially a whole lot of molecules that could be addressed and have been addressed or are being addressed. Just a very brief mention of one approach, the first to be clinically examined. There is a molecule, CNS specific, called LINGO-1, that if you neutralize it with a monoclonal antibody in the animal model of MS, you really promote repair and remyelinate the denuded axons. This prompted a clinical development program, 3 studies that one has to quite honestly admit haven't provided conclusive evidence, but there were hints that if one looks at patients with relapsing MS that receive either placebo or this monoclonal antibody do improve in disability. Finally, an important player that is the focus of much recent work are the microglia. This, by the way, is not just true for multiple sclerosis, also for Alzheimer's disease, Parkinson's. Microglia as the prominent representative of innate immunity in the central nervous system plays an important role in all these diseases and pathologies through a number of ways. Microglia come in different flavors, in a homeostatic subpopulation and a pro-inflammatory one. And you see here summarized in multiple sclerosis, this activated microglia that can generate free radicals, cytokines, other molecules that are injurious, and also synaptic loss, neurodegeneration, and they inhibit remyelination. And this clearly then has identified them as key players in the pathogenesis. We've had over the years an interest in human endogenous retroviruses and neurological disorders. These are genetic elements integrated into our genome some millions of years ago. And we don't know exactly the reason, but then they become activated in the genome and exert a number of pathogenic effects. And one that we demonstrated was that they can attach to microglia here, and then these endogenous virus positive microglia attack the axon and contribute to the damage. And we've embarked on a clinical trial to look whether a monoclonal antibody neutralizing this human endogenous retrovirus impacts the disease. And indeed, we could show that administration of this antibody slowed the development of brain atrophy. This is just to show you that the microglia has an important homeostatic function, fostering remyelination, and all attempts to modulate microglia have to be aware of the multiplicity of the disease promoting and disease inhibiting actions. And this comes then to the final part, just focusing on microglia and new ways to attack them. There is a kinase called Bruton's tyrosine kinase that is common to both B cells and microglia. If one blocks it, one disrupts important signaling pathways in both cell types, and both cell types being implicated as drivers of the pathology, particularly the progressive pathology. And there are now huge clinical programs by many companies to explore this specific therapeutic target. Finally, whatever drug you use, how can we sort of better find out those that are of use in a given patient? This is the concept of personalized medicine that you are aware of, the development high resolution DNA microarrays or second generation sequences this enormously active field with ongoing genomic profiling studies. New biomarkers are being sought and have been identified both in terms of body fluids, neurophysiology, evoked potentials come back into the limelight, and they may aid in orienting treatment decisions and monitoring. And of course, AI is just exploding and will allow the application of sophisticated data analytics to health, creating conditions for improved and innovative models of care. And the aim, of course, is to enhance patient care by generating data to support disease decision-making, predict therapeutic responses, and predict the disease course or treatment response. So in conclusion then, this was, I guess, a tour de force. I apologize. I try to briefly sketch out what we currently think about the etiopathogenesis of multiple sclerosis, briefly talked about EBV, the ever-broadening arsenal of disease-modifying therapies, the current focus on B-cell therapies, and Wnt tyrosine kinase inhibitors acting both in the periphery on B cells and the central nervous system on B cells and microglia. I briefly touched the avenue of repair promoting strategies and ended up with personalized medicine and how that may be implemented in the care of MS patients. And with this, I'd like to thank you very much for your attention.
Thank you, Peter, very much for a very nice inaugural lecture. We are very pleased also that you come to us after, I think, 3 years, COVID area. So we can continue in our long-term cooperation. Before I open the place for discussion to the auditorium, I would like to show reminiscence to our long-term cooperation and friendship. In 2000, based on recommendation of Professor Urbánek, who is sitting here together with us, you accepted me to internship to Graz, Uni Graz. There I could cooperate with Professor Fazekas on MRI criteria and the revision of Petit Fazekas with Arkelos it was lipology, and also with Kisaya on neuroimmunology. In 2003, you invited me to Düsseldorf, where you get the same position, head of neurology department. And I think it was a good starting for our neuroimmunological symposium that was grounded together with Professor Kaňovský. And thank you. And also to your colleagues, I think it became international format. Thank you also for the cooperation on the papers in last years. It was outcomes, results, reviews, and I have to say that one of the publication got today won Dean's Award. And we want together to thank Spectabilis for getting this award. We appreciate it very much. And I have also to say thank you to Peter. And last thing, Peter spoke about that you are a very important member of editorial board of biomedical papers. It's a long, effective, active cooperation, and I hope it will be also to the future. And your contribution, I appreciate very much. So it, from my point of view, and now I want to open the lecture to the auditorium. Maybe yes?
Peter, thank you. It was very nice. I have a question. Have you any experiments with rehabilitation of multiple sclerosis? Rehabilitation.
Rehabilitation, yes.
Well, personally, not, but this is a very important area. And I usually start when talking to non-MSologists saying that, of course, our approach must be multidisciplinary, must be holistic. It's not just drugs, it's the whole psychological support, it's occupational therapy, it's physiotherapy, it's neuro rehab. And there are, this I think is a scientifically very rapidly evolving field, you know, with for long just done empiric treatments, and now with network therapy systems, neuroscience, there are ways to look what does neurorehabilitation do to the disturbed brain or spinal cord. And I suspect or hope, very optimistic, that we will find ways to better design neurorehabilitation, which is a very important cornerstone of the overall management of MS patients. Absolutely.
Thank you for the answer. Are you satisfied? Okay. Another? Okay.
Thank you very much for your interesting talk, Professor. I would like to ask about your information about biomarkers of microglia. Sorry, it is some echo here. It was interesting in your talk, microglia is becoming a new target for treatment. And do you think are there some markers, biomarkers, showing activation of microglia in MS patients?
Thank you very much. Indeed, this is currently an area of intensive research. The most convincing evidence for microglial activation comes, of course, from PET imaging, better than the original radioligands that can demonstrate, of course, the utility in the general patient management is limited given the technique, the apparatus required. And there is a search for body fluid biomarkers like TREM2 or something. This is indeed, I think, not yet prime time, still intensive research going on, but clearly a mandate for us to identify those and then adducing evidence whether or not we impact the disturbed or aggressive microglial response.
Thank you. Peter?
At the current time, this, you know, the data of health economics, in my view, are a little shaky, but it's roughly up to 15%. So it's very similar to situation here. And of course, this is all these innovative medicines increase the budgetary requirements. And I don't have to tell you that in the face of the current global political situation, there is intense discussion, for example, about biosimilars, you know, producing similarly effective drugs at lower costs. We cannot strain our health system and society limitlessly. This is something besides science to help guaranteeing that, you know, all patients who deserve it will still get access to the most modern and most efficacious treatments.
Thank you. I will continue with practical question. In our Czech Republic, we have some problems with regulatory organs and in company insurance. So we have to start with basic therapy, and then we can escalate to high efficacy therapy, excluding CD20, what is very well when the patient is active due to MRI or clinic. So I think it's a good situation now. But my question is, how is the situation now in your country? Have you any regulation?
Well, first of all, of course, we are governed by the regulatory agent's approval, the label of EMA, European Medicines Agency, which in principle, of course, is binding for all of us in Europe. The second thing is reimbursement, and here, you know, each national society sort of adopts recommendations, and the German society has been very controversial. I must say that it was a relatively conservative camp, and a camp that is more active, that includes me. So we, or the conservative part of the society, adheres entirely to the labels given by EMA. So only very few patients would get high efficacy early on. Only the very most active are those that fail to other previous drugs. But this, I think, will change with the new ECTRIMS, European Academy of Neurology guidelines, and also the, I think now, overwhelmingly positive evidence that has been gathered over recent years, demonstrating the clear benefit of starting patients on a very active, very effective drug.
Thank you very much. There was an interesting slide when a bit personalized medicine to predict specific and right agent therapy treatments, and also the course of the MS. So I think the concept, for example, induction therapy can be also very important for part of the patients. As Associate Professor Kantorova said, we need prognostic markers. For example, the study outcomes MS Clarify, the patients after cladribine becoming after 2 cycles. We saw them after 10 years, and part of them, maybe 67%, are clinically in very good status. Thank you.
Absolutely. I didn't have time. It was not because it's not interesting or not relevant to delve on the issue of induction therapy, which means deliver one kind of effective drug that somehow reshapes the disturbed immune system, reboots it in a way. And cladribine is an example. Alemtuzumab, of course, is also an example where you know, a couple of courses result in very sustained stabilization of the disease. And yes, I think that's probably also becoming more important. The unlucky situation with alemtuzumab, you are aware of, EMA, because of some complications, vascular complications, relegated it really to 3rd stage or 3rd line treatment. But I think if we were to solidify the evidence that using induction therapy guarantees patients year-long freedom from disease activity, that would be extremely important.
Thank you very much for nice conclusion of this problematic. And I ask to the auditorium for any other questions. If not, I have to thank again very much for this excellent, nice evening or afternoon and beginning evening. I'm happy that we are here together with magnificent Professor Procházka and spectacular Professor Zadražil, also with our head of department, Professor Kaňovský. And my question is to, if Peter, do you want to end this symposium?
Thank you. So I would like to close this session. I thank our guests, and I thank you all for coming and making this event so nice. Please feel free to gather yourself in this small corridor in front of the lecture hall. It is all for you. And I'm particularly glad that we had our students here, because our visiting professors, we are proud of our visiting professors, that they are so nice, and they come to talk not only for us, but for our students as well. So thank you very much, and have a nice rest of the afternoon.